even in the early breast cancer, now we are in the era of whether to go for surgery or not. Okay, in metastatic breast cancer, it is all about overall survival. When there is indication like fungation, bleeding, that indications we can do a mastectomy as a palliation. It won't improve her survival. Okay? Unless that, even patients with fungation with good systemic treatment, it can be brought out. And we are avoiding many toy mastectomies, even that scenarios. So we have good agents to cover that thing.
So thyroid mastectomy nowadays the role is very negligible. Even with fungating tumor, with good chemotherapy, we are seeing very good response. So the role of thyroid chemotherapy is very limited, very limited.
Yes, so we have cases of thyroid mastectomies also coming forward. Do you have anything to add, sir?
Nothing. So no role of surgery in a metastatic breast cancer, unless the patient is having a severe bleed, and even in fungation we avoid generally. And there is no role for the patient. For yes, sir. Yes, madam. Yeah. Yeah, we do a skin biopsy. Yeah, if there is an infiltration, if the patient is having a skin infiltration, I don't do a core. Just take out the skin and give it to the patient. Yes, sir. Day before yesterday, we did one case like that, and it's a LABC.
Yes, sir.
We don't know the PET CT status. We are sent the patient for PET CT. It was infiltrating into the skin and bleeding. Just remove part of the skin, infiltrate in wherever there is maximum duration, and send it for biopsy.
Yes, sir. For this case, we had already taken core needle biopsy, but we just wanted to know whether it was safe to take core needle biopsy.
It is very safe, sir.
Yes, sir. We'll move on to the second question. It is a case of synchronous breast and ovarian carcinoma, sir. We had a 40-year-old female with invasive ductal carcinoma breast, incidentally found right adnexal mass on ultrasound. Initially, we suspected to be Krukenberg tumors. Diagnostic laparoscopy and biopsy revealed second primary ovarian carcinoma. The final diagnosis that was made was synchronous double primary malignancy with both breast and ovarian. Patient defaulted after chemotherapy referral, sir. The discussion points here is, after confirming double primaries, what is the optimal treatment sequence, sir?
So first, I think synchronous primary and breast and ovary, so high likely to be a BRCA positive patient. First thing, so young female, onset is very young, CA breast, and dual primary. So BRCA positive testing has to be done, and depending upon the stage, we have to again act. So we have to. It is not like if there is a synchronous primary, the treatment will change. If it is a breast, OBC, early breast cancer, if it is ERPR positive, HER2 negative, we have to go and do surgery for both primary and for both breast and ovary. But in this case, high likely it will be a BRCA1 mutation, which will be triple negative breast cancers. Usually BRCA1 mutation is associated with triple negative breast cancers. So what is the local stage of the breast in this case?
Sir, that was
T2.
it was T3N1, sir.
T2.
LABC.
So LABC basically do a biopsy for the breast, send it for a biopsy and IHC immunohistochemistry, give neoadjuvant chemotherapy. Neoadjuvant chemotherapy rounds, medical oncologist has to decide.
So I have one more, sir. Please tell me, sir.
Yes, sir. This is synchronous breast and ovarian, and high likely is a BRCA mutated. The one key point is, for BRCA mutated, they will melt with the platinum-based regimens. Platinum, like cisplatin and carboplatin, are the poor man's PARP inhibitor, we tend to say. It will melt away. So, if the patient is having an ABC and ovarian mass, better to go for platinum-based regimen for 6 cycles, then we can go for the definitive surgical management for both.
Yes, sir. Actually, this patient was treated with carboplatin and paclitaxel. As it's a triple negative breast cancer and also associated ovarian primary, we started carbo and pacli. After 4 cycles, we did PET. Actually, as you rightly said, it was melted like ice. There is no breast primary lesion and only ovarian residual lesion. Very minimal disease was there. But unfortunately, patient defaulted after that.
That is the problem with our patients. After the disease disappears, they will also disappear.
Yes, sir. We have another one synchronous dual primary, sir. I think I will. Please continue, sir.
Both the lesions are after.
if it is triple negative, we'll still do it with neogen chemo. Even if the ovary is operable, yes, ovary should be operable. There is nothing called as inoperable in this case. If it is early breast cancer and if it is triple negative, go for a neogen chemo. Then do surgery after, if possible, 4 cycles of adjuvant.
Yes, sir. This was a breast and ovarian carcinoma.
Suppose the breast is a hormone receptor positive, both are also.
One second.
If it is early breast cancer, if it is hormone receptor positive, HER2 negative, I'll go and operate upfront. Both sides. Yeah. When you are planning for surgery, you have to plan for surgery for both breast and ovary. Whenever, whether it is before chemo or after chemo. If it is upfront, both surgeries for breast and ovary. If it is after chemo, both surgeries for breast and ovary. The timing of surgery depends on the local staging of the breast and also the ovary.
So that patient, the breast was locally advanced. So since it was locally advanced, chemotherapy was given, but unfortunately patient defaulted to follow.
Triple negative, it's not a locally advanced.
LABC. Clinically it was LABC.
Clinically.
So we have one more synchronous dual primary, sir. This was a case of idiot neuroendocrine tumor and breast BCA, sir. She was a middle-aged female presented with subacute obstruction. DLAP was done and it revealed ileal structure. Ileostomy was done and histopathology showed the neuroendocrine tumor. PET scan revealed metabolically active breast lesion, BCA was confirmed. She underwent MRM and is currently on chemotherapy.
Excuse me, it's not a DCAS, it's an invasive carcinoma. Yesterday I corrected, she is now on chemotherapy.
So the discussion point here is there any diagnostic criteria for double primary tumor metastasis?
No, so such things occur rarely. There is no correlation between a breast carcinoma and ileal carcinoid. They are very rare scenarios. Just treat accordingly. So ileal carcinoid, see the grade of the status and Ka67. If it is neuroendocrine grade 1, 2, 3, treat accordingly. And for the breast, treat according to the stage of the patient.
Yes, it is actually well differentiated neuroendocrine
I think we
tumor,
don't
non-metastatic.
need, no need for any other adjuvant treatment for the neuroendocrine
So
part.
that's why I wanted to rule out any metastatic lesion. I asked for that serotonin receptor uptake scan. That lesion picked up a breast lesion is a T2N0.
Okay.
PT2N0. ER positive, PR negative, and H2 negative. But patient is not willing for risk analysis score. So that means they must explain and started chemotherapy.
Yes. So mastectomy followed by adjuvant chemotherapy will be the treatment of choice. That's it.
Dinu Dayalan sir, would you like to add anything, sir?
Basically, you want to differentiate whether it is two different primary or a primary with distal metastasis. Is it your question?
Yes, sir. We need to know whether there is any criteria for diagnosing.
We have immunohistochemistry. Okay, for neuroendocrine tumor, there will be separate markers. For breast, we tend to check with the ERPM. The ER positivity confirms that is the primary tumor. And the synaptophysin, chromogranin, that are neuroendocrine markers that will confirm that the ileal tumor will be the neuroendocrine tumor. So we have the facility of immunohistochemistry now, and beyond the histopathology, we are more dependent on the IHC for the proper subtyping.
And the second one is genetic testing indicated in dual malignancies, sir?
As I said, first thing, sir, I just want to add what sir said. So, without a good oncopathologist, whatever we give, it will be wrong. So, if someone has said that this is metastasis from the breast primary, we have to agree upon. Even though it is rare, we have to agree upon. We have to treat the patient as metastatic. We have to prognosticate to the patient that you are at stage 4 breast cancer, your survival will be so and so. So, oncopathologist actually does a more job than any of us, really. First thing. Second, there is no, as I said, for a genetic testing, breast and ovary, yes, we do have a BRCA mutation which causes these two cancers simultaneously or in a single patient or familial. For ileal carcinoid and breast, it is very rare. There is no known genetic mutation which causes such scenarios. It's rare, coincidental, both incidental primary. So there is no genetic testing according to be tested, to be done.
Absolutely, as Sir told, there is no syndrome which can explain the occurrence of both. But newer things are coming up, like we have the panel testing now, which check the around 150 genes of common familial cancer. Somebody has breast cancer and other malignancies, and now we are moving towards a panel testing where common 150 genes are being tested. It includes the common BRCA1 and 2, HRR, that is the pathway. It is involved in the, if it is BRCA mutated, the HRD pathway will be involved, so that all genes will be studied. Okay? So the uncommon things can be explored. The cost of that panel also coming down. Okay? The patient has multiple family members with a malignancy. We can go to check the hereditary panel testing. We can explore some uncommon gene.
So we have been please answer.
Actually, that the breast and ovary, that case. Actually, in our setup, we cannot do multiple tests and all. Actually, we applied for young patients. Initially, we thought of Krukenberg, and then we did the biopsy from the both sides, breast and ovary. Ovary is also, they have given us serious carcinoma positive for malignancy. And then breast is also, then we planned for hormone receptors. If it is positive and if this specimen is also positive, we can take it as Krukenberg tumor. ERPR positive in both the breast and ovarian specimen, then we can take it as a Krukenberg tumor. Otherwise, as a double malignancy. Then unfortunately it turned into triple negative. So in that situation, actually we have to do further GCD-FP and all to confirm the primary, but in our setup we don't have that much of it. So we did only ERPR in breast tissue. So if it is turned into positive, then we can do that also in the ovarian specimen. But if it is triple negative, in that situation, how will you proceed?
Clinical decision. Actually, in the resource limited setup, we have separate guidelines. Cannot be applied. Since more students are here, we are speaking about the real facts. But the resource limiting setup, we have to follow the department protocol.
IHC is mandatory. Basic IHC has to be there. We have very well labs everywhere. So I think we should ask the government to give some proper IHC markers for ovarian cancer. CK7 and CK20 is those two markers will apply for ovarian malignancies. No, we can 3-4 markers we can identify whether it is a primary from breast or a primary ovarian malignancy. So basic IHCs I think should be there, and then we can ask for it.
So we've been talking about the clinical settings a lot here. So basically all these cases have been from our wards in a clinical setting. So final PGs who have seen these cases in real time can ask you questions if you have, or the clinical scenarios which were elaborately detailed here. So we've been talking a lot about the PET today in the lot of discussions. So what is the role of follow-up PET in such cases, sir? In a government setup like us, it may not be very feasible. So from upper-low basis, like what do you do, sir? Do you have follow-up of PET in these kind of dual malignancies, sir?
Follow-up PET.
For these cases, after any curable, any treatments given to these patients, do you follow it up with PET too?
As I said, like for a breast malignancy, I'm talking about breast malignancy, we don't usually do any investigation, leave about PET. We don't usually investigate the patient. We do only a clinical examination every 3 months and a mammogram
That
every
we
year.
elaborately discussed during
Yes.
the discussion.
For this
when
case,
we have a two primaries,
for
we
this
go
case,
for PET.
yes, for this case, as Madam said, it is a neuroendocrine grade 1. That's the best tumor to have.
Yes.
We have operated on neuroendocrine tumors, and the patient lived for 10 years without any recurrence. We are not investigated. You can take, there is no guidelines for it. So I don't advise a PET directly. If you want to do a PET basically after the completion of treatment, yes, it is okay. There is no individual guidelines. So if you want to do a PET, yes, but there is no need for it.
In the scenario of not an neuroendocrine tumor, which is a good tumor, as ma'am said, if it's two primary tumors, just two primary tumors, do you advocate PET, sir?
That does.
The number of primaries does not decide the aggressiveness of the primaries. So if you are talking about some other malignancy which is, let's say, we are dealing with a small cell carcinoma, the patient has a high likelihood of the metastasis. In that case, we will probably clean. If it is a RCC which is early stage completely resected, we will probably not do. So depends upon the aggressiveness of the individual primaries rather than the number of primaries.
If it's an esophagus, as sir said, if it's an esophageal malignancy, we do PET. If it's a lung malignancy, that too in the follow-up setting, we don't usually do PET, but in the preliminary setting, we do PET. The aggressiveness of the disease should determine the investigation, not vice versa, the number of malignancies.
It is generally not done unless there is suspicious of recurrence in the clinical follow-up. It is a over-investigation and it has its own demerits like radiation exposure. So we are not routinely doing PET except at the baseline and the staging.
Even also PET is mainly indicated for lymphoma. Even in lymphoma, as per NCCN guidelines, during follow-up, PET is not at all indicated. First the baseline, first staging workup, then after 2 cycles for response assessment and continuation of chemotherapy. And if there is, they have clearly said, if after 6 cycles of chemotherapy, completed chemotherapy, we will do another PET, only 3 times PET. In that PET, if it is not complete remission or SUV less than 3, then only we can do after 6 months. Otherwise, after completion of chemotherapy, it is complete remission, but it is not at all indicated. We have to do contrast and CT only, even in lymphoma. So PET is not routinely indicated for other malignancies.
And we do also get false positives. As sir said during his presentation, we do get a lot of various blood nodes. So we don't know how to correlate this, and we usually compare those images with any images done before, like 2-3 months before the patient had got any CT scans. We compare the size of the nodes. Even if there is a bit uptake in the mediastinal nodes, we compare the size of the nodes. If it is static, we'll think it as the mediastinal nodes from a previous TB which is indolent for that patient. Because any patient, if you do a PET, any of us, if we do a PET, we may get a mediastinal node because our is a TB prone area. Thank you.
Thank you.
In the context of follow-up, I just want to point out that in a malignancy patient, there are very few indications for a plain CT at all. The only probable indication is to screen for lung metastasis with the low-dose CT. Any other CT that you are ordering for a CA patient, make sure that you give with the contrast. With the plain CT, whatever has been given, it has to be thrown out, and again another imaging with the contrast has to be done. So make sure that whatever CT you are ordering, make sure it is with contrast.
PGs, do you have any doubts on PET scan? Can we move on? So, ma'am, we move on to the next one. Thank you. We had a case of multiple bilateral fibroadenomas in a seizure disorder patient. It was a 21-year-old female, known case of seizure disorder. She presented with multiple fibroadenomas involving both the breast. FNSC confirmed fibroadenoma. Surgical excision was performed as per the patient's wish and leading to significant breast tissue loss. Here we are talking about a 21-year-old female. So the discussion points here is there any connection between the seizure disorder or low IQ and multiple fibroadenomas?
I don't think it
No, these are basically questions selected by PG, so they had a discussion and they had doubts about that.
I don't think there is a connection between seizure disorder and fibroadenomas.
Related to this question, I was like, who came up with this idea? Relationship between IQ and fibroadenoma. Some patient has irritated something.
Okay, so moving on. So what could have been done to preserve the breast tissue in such a young patient, sir?
So we better to avoid surgery if it is a fibroadenoma.
Unless it is very significantly symptomatically they feel bad or it's very bigger, I don't usually go in and do fibroadenoma.
What if there was a giant fibroadenoma?
Yeah,
We had cases,
we do.
even in a 13-year-old.
That's what I said. If
Yeah.
it is symptomatically like worrisome for them, and if it is bigger in size, yes, we do.
Giant fibroadenoma.
Yes, we do.
Yes, definitely giant fibroadenoma, beware of Phyllodes tumor.
Yes, sir.
So any giant fibroadenoma, FNAC cannot differentiate between a Phyllodes and fibroadenoma. Even core needle biopsy sometimes cannot be, it will not be able to differentiate between a giant fibroadenoma and a Phyllodes. In that case, definitely surgery is indicated because you may miss Phyllodes. But multiple small fibroadenomas, both breast.
said 2x2 and 3x3 only, ma'am, not more than that.
Only two.
No, ma'am, multiple.
Multiple
Both
also.
procedures are, yes, ma'am.
Generally, I don't operate if it is less than 3 centimeters. If it is not painful, if it is not giving any symptoms for the patient, we don't give operate.
But this patient actually it was done as per patient's wish, sir.
That's what,
Like
if patient is wishing, and if there is a significant breast loss, I refer to a plastic surgeon so that they can augment the breast and do such.
Moving on, sir. Uncontrolled hemorrhage in fungating carcinoma breast, sir. Like we were talking about the palliation. 80-year-old female with advanced fungating breast carcinoma presented with active bleeding. It was unresponsive to compression. Emergency cauterization was done, but rebleeding occurred after 2 days. Toilet mastectomy performed for local control. Hemostasis was achieved. Patient stabilized. The discussion points here was toilet mastectomy the right choice in this setting, sir? So before I start, I will give you that it was as it was given as a fungating mass, it is a little larger in size. So once we operate, it can go for recurrence. Even if it comes back, it will be like coming very faster also. Rapidly it will be growing. So should we do a toilet mastectomy, sir? And in the setting of this is perfect for the PGs because like there was active bleeding. In the wards they would be cleaning the wounds, but due to active bleeding, they won't know what to do actually in the wards. So this should be very helpful for the
Generally bleeding from tumor should get compressed, sir. Generally,
Yes, sir.
I am not seeing such an active bleeding, such an active spurter. If you have planned for a toilet mastectomy, it should not delay the treatment onset of systemic therapy. That's the only catch. So, 80-year-old systemic therapy has something he can give, right? So, if the toilet mastectomy with good flaps, if you can remove the sutures on day 10, day 14, and give the patient, hand over the patient to a medical oncologist, yes, it's a right choice. If you can't do that, there is no other choices like embolization. Usually, compression will help in most of the cases. And after compression, give a palliative RT. Even I won't advise a palliative RT even in such settings. If you start systemic therapy, the bleeding also will reduce. And extreme situations, you have done a toilet mastectomy. If you can, if it is not involving the inframammary piece, and you can get a proper closure without much tension, if the wound heals, if you know that the wound will be healing by day 10 or day 14, and you can hand over the patient to a medical oncologist as soon as possible, then yes, we can do it. There is no right or wrong in the situation. It depends upon the patient.
And then the toilet mastectomy, regarding toilet mastectomy, if it is operable by closure, you do it. Suppose if the tumor is fixed to the chest wall and if it is huge, there is no role for toilet mastectomy at all. And hemostatic RT, most of the time, it may be very helpful.
Any points to be added on embolization?
On paper, yes, sir, but I don't think we have the expertise.
Sure, sir.
The embolization is for feeding points which are not accessible, it is on the skin. So radiation will work very well. So 5 days of radiation, the bleeding will excellently happen.
Do we have any criteria to delineate between surgical palliation and conservative management for such patients, sir?
As a medical oncologist, we tend to have a problem with this toilet mastectomy. Often what happens is, after the toilet mastectomy, the approximation won't be proper. They will be presented to us with a huge wound cap. The management of that wound cap is a nightmare for them. So choose the patient. The approximation is possible, then please proceed for toilet mastectomy. If it is not that, better we can give a hemostatic RT. This is a simple procedure if the machine is available. Okay, then we can kick off the systemic treatment along with the hemostatic RT, and it will settle down. So toilet mastectomy, choose the patient wisely.
So
Actually, what Sir is saying is don't create a non-healing wound and hand over to a medical oncologist.
the main aim of this patient should be to start systemic treatment as soon as possible. You are aiding in controlling the symptoms. So whichever way it is early, whether by surgery or radiation. As Sir said, if your flaps are easy to close, it's just at the one end where the bleeding is occurring. You will do a surgery, give a healed wound to the medical oncologist. Don't give a non-healing wound to the medical oncologist. If that is not possible, if it is a larger wound fixed to the chest wall, extending beyond the breast skin, then better give it to RT, let them give 4-5 radiations, control the bleeding and give the patient to medical oncologist as soon as possible. The main aim is to start systemic therapy for this patient as soon as possible. Because we are not going to treat the patient locally, regionally, either radiation or surgery. He is going to treat the patient. He may give some overall survival to the patient better than us.
Regarding chemotherapy, actually age is not the criteria, only general condition. Actually, I have given the chemotherapy at the age of 96 years. So age is not the criteria, general condition is more important for chemotherapy.
So in that case, ideally toilet mastectomy has to be avoided. I don't think compression won't control a bleeding because there is no spurt area, there is no active bleeder, that you are not going to handle a perforated vessel. Compression, give the patient to RT, they will do a hemostatic RT, let them do 4-5 days, hand over the patient to systemic therapy. In that case, surgery may be avoided, would have been avoided. I would have avoided a surgery for that case without a proper closure. That's all for next case. Like if you may wonder, give the patient what is the ERPR for this ERPR? Basically, hand over the patient to a medical oncologist. அவங்க ERPR HER2 பார்த்துட்டு if just do a compression, even now it will bleed. I think even now it is bleeding somewhere else because the open wound obviously will have exposure. Do a regular dressing. Meanwhile, try to heal the wound by giving chemotherapy. You have to control the source, right? You have to control the source by giving treatment to the cancer. So the wound will heal automatically if you are treating the cancer. Yes, no need for any further surgeries.
You could do a skin grafting. You want a closed wound right now. You don't want a bleeding ulcer to be given to a radiation or a medical oncologist. You could do a skin grafting wound, heal the ulcer, close the wound completely.
Is it a metastatic
It's
disease?
not the best ideal treatment. Skin grafting would be better.
Is it a metastatic disease?
Another thing is that wound gap. Most of the time we will think that it is a gap. Sometimes it will be a local reference. It won't allow to approximate. In that scenario, we will be forced to start systemic treatment despite there is a noise.
Most of the time it is a compressive band that is going to help by stopping and for the time to recruit all the other factors to complete. So this patient I deferred
And the only thing is, before putting compression dressing, we have to put either Vaseline gauze or a Sofratul before putting any bandage. Otherwise, when you are removing the bandage, it will bleed.
Thank you, sir. The next question is a benign appearing lump which turned to malignant. We had a 50-year-old female with right breast lump which was 2 × 3 centimeters, firm, mobile. FNSC suggested fibroadenoma. Excision was done, and histopathology revealed invasive ductal carcinoma. So the discussion points here is how common are false negative FNSCs in breast lumps?
It depends upon the pathologist. See, interpreting the FNAC is the role of pathologist. The pathologist has to be more experienced in interpreting the FNAC. Some studies has told that it can be up to 15%, but that is the criteria. It depends upon the pathologist. But what is the ultrasonogram finding?
Everything almost suggested fibroadenoma.
Mammogram findings.
Sir,
Mammogram is the right investigation.
Mammogram for a 50-year-old breast lump. That is, even if it is given as fibroadenoma, do a mammogram. Before that, usually when we read, we say trained cytopathologist is required to interpret an FNA. I used to think like what trained cytopathologist, everyone can read a cytopathologist, but we are realizing in current scenarios, but it is very difficult to give a report on an FNA. It is very difficult to get a trained cytopathologist even in tier 2, tier 1 cities. It is always better to do a true cut biopsy. And a 50-year-old, mostly, even if it is a fibroadenoma, do a mammogram, do a true cut biopsy, confirm that it is not malignant, and then you can manage that spot. Even now, there is nothing wrong in after excision, you got a IDC, so you treat like that. Now, assess the stage for the patient. This is a 2 into 3 centimeter lump. It should be a T2 lesion. Mammogram, whether there is any axillary node or not, and you have to do a immunohistochemistry for this patient, ERP or HER2, and treat accordingly. I think this should be an early breast cancer.
This is a take-home message for all PGs. Even if it looks just like a fibroadenoma and the patient has taken ultrasound, if the age is greater than 40 years, please send the patient for mammogram and then proceed on further. So the second one will be, sir, should intraoperative findings modify surgical extent in such cases? In this case, it will be like only T2 and 0.
Yeah, how was the clinical findings? Is it hard?
It's a hard, sir.
Why
Hard
you can
is
do like if it is hard and if you have a suspicion, as sir was saying about discordance in the morning, right?
Yes, sir.
You have a clinical suspicion of malignancy, biopsy came as fibroadenoma, you could have done a wide excision, send the sample for frozen section. If frozen is positive, I do such settings. If I am clinically suspect a malignancy in a patient and the biopsy came as negative, I won't send the patient away. Even after a mammogram, I do a wide excision, treat it as malignant, do a wide excision, send the specimen for frozen section. If frozen is positive, I complete the axilla or do the axillary staging in the same setting so that we can avoid another surgery. But here you can do a wide excision so that if the final report after 2 weeks comes as IDC, infiltrated rectal carcinoma, you don't have to address the breast. You don't just do a axillary staging now. It will be a breast conservation surgery. Now there will be contamination in the breast, and we don't know which tumor, which sites are like positive. So ideal case, if the patient wants a breast conservation, IHC if it's triple negative or HER2 enriched, go for neoadjuvant chemo and then go for wide excision of the scar. And if the defect is greater, do some filling of the breast and then do an axillary dissection. And if the patient doesn't want a BCS, go for an MRM after IHC.
In a scenario where frozen section is not available, sir.
That's what I said. 2 weeks, wait for 2 weeks. After 2 weeks, again everything will depend upon the IHC, sir. ERP or HER2, if it is ERP or positive and HER2 negative, patient doesn't want breast conservation, modified radical mastectomy upfront. If ERP are negative and HER2 enriched or triple negative breast cancers, give a neoadjuvant chemotherapy, then go for modified radical mastectomy if the patient doesn't want a BCS. If the patient wants a BCS, then you have to give a very wide margin and then fill up that area with some autologous tissue transfer.
I think, sir, you have answered for the third question also. So we move on for the next one.
Yeah.
So the next one is false negative biopsies. It's a 55-year-old female with fixed breast lump and no nodes. Co-needle biopsy twice negative over 1 year. Third biopsy sent, reports are awaiting. Strong clinical suspicion on malignancy versus so the clinical discussion point here is, when should negative biopsy results be disregarded based on clinical suspicion? If we have a strong urge that
Is the tumor progressing after 1 year during this course?
No, sir.
That's a single most important point for me. Like if it is a breast cancer, if it is a cancer anywhere, even if it is slowly growing, it should be progressing, right? Anyway, we have got 2 biopsy reports, negative biopsy reports. If the patient comes to me again with a lump, I will go for a wide excision for this patient, do a frozen section. If no frozen section, I will do a wide excision, send the patient for fill the thing for histopathology, wait for the histopathology report, and then you can decide. Instead of going for a third biopsy. Because we are not going to get another different reports by doing a third true cut biopsy. Right? This is what I feel.
Send to a different pathology center.
Yeah.
If you are going to send to the same pathologist, you have to take out this specimen. This is what Sarah was mentioning about the discordance between the 3 modalities. There is a discordance, try to think differently. like another biopsy to the same pathologist.
Will give the same results. So what if one report had a high grade of dysplasia, but we didn't have any DCH component, but the second one was inconclusive, we are sent for the third also. Can we take for MRM or should we wait for a conclusive?
No MRM, sir.
I mean, for
No MRM.
surgery, sir.
Surgery, yes, wide excision we can
Wide
do.
excision we can take.
Well, you can do wide excision, but not an MRM.
So what alternative diagnostic tools can be used, sir?
So first mammogram. Here also.
So what do you mean by fixed breast lump?
Fixed
Yeah, what is
chest
fixed?
wall or some other thing. What you are meaning that fixed lump response?
So is it fixed to the skin or is it fixed to the chest wall? Because if it is fixed to the skin, that is different. If it is fixed to the chest wall, that is different.
Let's see the case scenario.
Okay, in this case, the true cut biopsy, first true cut, say for example, you are having a lump, hard lump fixed to the chest wall. You are doing a core needle biopsy, it is inconclusive. Then you better to take a image guided core needle biopsy from the representative area. The second biopsy is also negative, but clinically you are having a very strong suspicion. Better you go for a open incision biopsy. If it is fixed to the skin, if possible, you can go for open excision biopsy.
And counseling these kind of patients will be like kind of tricky, sir. So what do you suggest in your practice?
Generally, we tend to do image guided biopsy for your pan mass also. So it will be more representative and this kind of errors can be minimized.
So we have the
Just to add, if you follow a tool, it's like a mathematics.
Yes.
Any patient with a breast lump, triple examination. If the patient is coming with a biopsy report from done outside and inconclusive, see if the patient is having a mammogram. If there is no mammogram, do a mammogram. Mammogram is more suspicious, repeat a guided biopsy. Usually we do by biopsy, we do a guided biopsy. Guided biopsy, like we can avoid errors even in the first setting, if tried to do it. If not possible, a senior should do a proper biopsy and that should be sinking course. There are basic steps standards to be followed. It should be sinking course, that course should be hard, you should be knowing it when you are hitting the tumor. And even after 2 tests, that a biopsy report is negative and you are feeling a hard mass which is not increasing in size, it may not be malignant. But anyway, the patient has come to you again with a lump, I will go for a wide excision if the mammogram is not supporting it and send it for a frozen or a foreign histopathology.
Somebody move on, sir. So the last question of the discussion today is a recurrent breast cancer after incomplete adjuvant therapy. It's a 58-year-old female. Mastectomy was done 3 years ago. Defaulted after 4 cycles of chemotherapy. Presented with local recurrence and multiple skeletal metastasis. Completed 10 cycles of radiotherapy for palliation. The discussion points here is how can treatment default be prevented in rural or low compliance patients?
Proper counseling. After the surgical management, we have to counsel the patient. Surgery has removed the visible tumor. Still the micrometastasis will be there. It should be removed with a proper systemic treatment. Then only you will be cured. The message should be conveyed to the patient. Then only they will be adhered to the schedule because there is no tumor for them. For that only they have come, you have operated, so they will be happily go back. So counseling, that is the idea.
Very well educated patient will think that I have undergone a surgery, the tumor has been removed, why I should undergo chemotherapy? This is the first question if we say. We have to ensure that we are giving that proper counseling, that your tumor will 100% recur if you are not going to get the treatment, complete the treatment. You have to, you can say a little, we can frighten them to a little extent that they complete the therapy. First thing. Second, in rural,
One practical issue is we don't have a centralized registry for follow-up. So like even for patients on treatment. The patient has finished 2 treatments, 2 cycles of chemo. The 3rd cycle of chemo, the patient has to suppose on the next day. If the patient does not come, we have no way of knowing that. So we will only know when the patient comes after some RDM or so in high volume setup, it is not possible to track every patient. So it is the counseling that is going to make the patient come, not any follow-up or trying from other side. But in setups where there is a digital records, where there is a ability to follow up, we can call them and remind them at the date when they are supposed to come. So that is one way if it is possible.
There is some, you can allot some separate PG to
So
maintain the
phone call
records.
reminders.
To maintain the
There
records.
can be a chemo registry. So every third week are they coming or not? If somebody is not coming, probably a phone call will make the patient come.
We should have a
Actually-
registry for each and every.
So actually in our department, we, for insurance purpose, we used to collect the numbers, and in spite of calling, they won't come, that is the issue. Actually, every time, every 21 days, we have a registry, they won't come, otherwise, within 1 week, we will call the patient. They won't attend or they won't come.
ரொம்ப கஷ்டம் சார் அந்த மாதிரி பேஷண்ட்ஸுக்கு
Patients
வந்துட்டு
will eventually come.
will come after some time. இந்த பேஷண்ட்ஸுக்கு வந்துட்டு we never offer BCS. We see the socio-economic status of the patient. And if such patients, if they are not asking by themselves, and if after explaining in detail, if we think that they are not going to get follow-up, even for a 1 centimeter tumor, I will do a mastectomy for such patients. Better because BCS பண்ணி அதுக்கப்புறம் local recurrence வரதுக்கு at least we can do a mastectomy and we can avoid such things.
Sir, I think it will be better to answer, sir. What are the palliative options for skeletal metastasis?
As I was discussing earlier, multiple metastasis or oligometastasis, depending upon the resources available, if it is the low resource setting, you can give palliative radiation, 10 settings as the given here. If the patient has, let us say, 1 or 2 metastasis, it is sitting in the spine or some weight-bearing area, if it is a high resource setting, probably we can think of high dose radiation. We call it SBRT. So which will give a more durable tumor control locally and allow the patient to have better quality of life for a longer duration, if that is possible. If that is not possible, 10 days radiation will make sure that the patient is at least pain-free. The thing is, the pain will come back, let us say, after 6 months or 1 year, depending upon the aggressiveness of the tumor. At that time, we can again irradiate if possible, depending upon the disease we will.
The last question, is resurgery indicated, ma'am?
After radiation, we can add bone body failure.
Yes, sir. Yes, sir.
No surgery.
No resurgery.
Even an upfront metastatic setting or recurrent setting, there is no surgery for metastatic breast cancer, sir. Unless there is, like, obviously we discussed a lot with bleeding palliation.
There is in oncology, any cancer treatment, it is called as a tailored treatment. இது 40 வயசுல எல்லாருக்கும் ஒரே சட்டை அப்படி கிடையாது. It's a tailored treatment. So even in metastatic disease, there is a role for surgery. அது எப்போ அப்படின்னா, patient is having metastatic disease, you are given the chemotherapy. Nowadays, very advanced drugs treatment is available. After completing the systemic therapy, we can take a PET CT. Suppose all the metastasis has disappeared, but patient is having disease localized to the breast. In that case, as a continuation of treatment, we can give surgery as an option to the patient. Here, the role of surgery is not curative, not staging, but it is a part and parcel of the treatment. So like that, the patient is having local recurrence, metastasis, you are giving systemic treatment. After systemic treatment, after evaluation, if all the metastatic sites disappeared, but the patient is having disease in the local area, if it is operable, then as a part of treatment, we can offer surgery. Otherwise, there is no role for surgery.
This is a paradigm shift actually. So only I didn't touch upon this particular topic. As Sir told, once upon a time in metastatic setting, the fungating mass we reserved surgery. Now in metastatic setting, who have responded beautifully, we are reserving surgery for this population. Totally changed that. So I don't want to confuse you. So only I didn't reveal this point. Actually, the metastatic setting, the role of surgery is only for those who responded beautifully and the only small disease left behind the breast that we can consider.
Oligometastatic setting is something a different entity, sir. So we treat the patients in general with the intent of treatment. We call it as whether it is curative or palliative. Up to stage 3 previously we call it as curative intent, and stage 4 we call it as palliative. But oligometastatic is in between stage 3 and stage 4. Because 1 to 3 metastasis, the numbers may vary, and solitary metastasis where you can treat them with the curative intent. Because we recently had a patient, completed the treatment, BCS, she had a local recurrence, no other sites of disease. So that's a oligometastatic setting, metachronous oligometastatic center. Still the intent was curative for the patient, so we proceeded with the completion mastectomy. We had given an adjuvant treatment for the patient. So this is how you should generalize, like it's an individual patient to patient discussion. If the distance spread, definitely I won't touch it upfront. Probably after all advanced modalities, the patient disease is localized only to one area, we may think, which is usually very rapid.
So you can think of it as like for resistant infection, you can take it 2 or 3 steps. Right? So likewise, in a patient with stage 4, when one of the system therapy has addressed most of the tumor, the PET shows near complete response except for one side. Which means that particular clone of cells are not sensitive for this therapy. So you can add one more therapy to address that. So only this local therapies become important only when the systemic therapy is very effective. Because with this newer drugs, we are able to achieve like very durable, long-standing responses. But there will be isolated disease, isolated sites of disease. Those will go on to progress and cause symptoms. That is where this local intervention goes. So think of it as like multiple clones being addressed with multiple therapies.
So again, this institution policy. When I worked in Omandurar, in tumor board we decided for young age patient, even in metastasis, after completion of chemotherapy, we used to do PET, and if it is complete remission of metastasis, we can do surgery. So again, depends upon the institution policy. These are the practical points, but still, at the exam point of view, metastatic surgery we cannot do.
Fungating tumorல டாய்லெட் மாஸ்டெக்டமி வந்து இண்டிகேஷனே இல்ல. The role of toilet mastectomy is very minimal. அது எதுக்காக அப்படின்னா இந்த LABC fungating tumor நீங்க neoadjuvant systemic treatment கொடுத்தா it will respond beautifully so that after that we can give the proper definitive treatment. எடுத்த உடனே ஒரு டாய்லெட் சர்ஜரி பண்ணி திரும்ப ஒரு adjuvant therapy கொடுத்து திரும்ப ஒரு definitive surgery வந்து அது so அதனால we have to tailor the treatment to the individual patient.
So I think that take home message is like if there is a bleeding tumor, refer to the medical oncologist.
If you approach a breast cancer, it is not operable, it is operable. Basically, it's a holistic approach. So as a team, we have to assess what brings the better survival to the patient, and accordingly you have to devise. And of course, the guidelines may not be possible in all places. In resource limiting setup, you can devise your own protocol, and you can follow to bring the maximum results.
Anything to add, ma'am? Thank you so much, sirs and ma'am. The panel is open for questions. Anyone who wants their questions to be clarified, please raise and you can ask the questions.
Sir, good afternoon. Good afternoon, ma'am. We have a similar scenario discussed earlier. Instead of fibroadenoma, we got the report as ductal carcinoma used to do. So we went for a wide local excision. But in post-operative report, HP report, we got the specimen with an invasive components. But margins are all negative, and there is no other symptoms or no other evidence of metastasis. So whether we should proceed for scar recurrence or go for a modified radical mastectomy or any adjuvant therapy.
Again, it's a mammogram. Mammogram, I will, if not done, it's a difficult scenario. We don't know whether we have diffuse microcalcifications in other
There is
quarters.
no other abnormalities.
So, if no other abnormalities, only single site IDC, no distant metastasis, and complete the axilla. You have to advise surgery for the patient. Do a axillary staging, either a sentinel node biopsy if it is clinically node negative axilla, or if you don't have a sentinel node facility, go for an axillary dissection, stage the axilla, and then hand over the patient to the medical oncologist. Do a ERPR on the specimen which you have received, ERPR HER2. Then we can discuss in a tumor board. Hand over the patient to the medical oncologist if it is triple negative or HER2 enriched. If it is T2N0 postmenopausal, ERPR positive, HER2 negative, do a CAN assist. CAN assist the low score on the chip observation. But VCS பண்ணிருக்கீங்க, so endocrine adjuvant radiotherapy, endocrine therapy. So that is how it should be.
Sometimes வந்து true cut biopsyல வந்து it will be reported as a atypical ductal hyperplasia. நீங்க wide local excision பண்ணீங்கன்னா அதே ஸ்பெசிமென்ல atypical ductal hyperplasia இருக்கும், DCIS இருக்கும், invasive component இருக்கும். So அதனால வந்து after surgery if all margins are negative, mammogram normal, if the patient is willing for BCS, you address the axilla. Suppose if the patient is willing for mastectomy, you complete the procedure.
Any other questions from the forum? So thank you so much, panelists, for your knowledgeable discussion.